to hyponatremia. An even scarier number is that 40% of patients who were hospitalized experienced hyponatremia if their hospital stay was longer than 1 day. This study was performed by the University of Toledo at St. Michael's Hospital in Toronto, Canada. Hi everybody, my name is María Cordero, and today I'm going to talk about diagnosis and treatment of hyponatremia. So let's start with the definition. Hyponatremia is a condition in which the amount of sodium in the blood is lower than normal. The normal serum sodium levels are between approximately 135 to 145 milliequivalents per liter. Now let's watch a video in which Dr. Weber is going to explain us more about hyponatremia.
Well, 0.9%, 3.5%, 31%. That's the sodium concentration of the blood, the ocean, and of the Dead Sea, respectively. Sodium chloride is intertwined with human history for thousands of years. Roman soldiers were sometimes paid in salt. In fact, the word salary is a derivative of the Latin word for salt. When Marco Polo traveled to Tibet, he found that people pressed cakes of salt into discs that were then embossed with the seal of the Great Khan and used as coins. It was protests over the salt tax that caused Mahatma Gandhi to lead the Indian people to eventual national freedom. Wars have been fought and trade treaties brokered over salt. Salt's used as a preservative for our meat and fish, as well as to season our food. All in all, it's fair to say that sodium chloride runs in the blood of civilizations. A society cannot survive without supplies of salt, and neither can the human body. Too much, and you risk coma and death, and too little, and you risk coma and death. Our bodies are incredibly adept at maintaining a very narrow range of sodium in the blood, but there are a lot of conditions that can throw that balance off. When that happens to one of your patients, you could be facing life-threatening medical emergencies. The decisions that you make in the first hour of managing a patient with severe hyponatremia or hypernatremia can mean the difference between whether that patient walks out of the hospital as a normal person or whether they have permanent brain injury or even death. I think that the way that most of us approach sodium disorders is that when faced with a serum sodium that's either too high or too low, we go to a textbook or to an online reference and try to fit our patient into a complex algorithm, usually without understanding the mechanism of the sodium problem in the first place. Well, today on MedNet, we're going to not just tell you how to manage hypernatremia and hypernatremia, but we're going to make the complexities of sodium homeostasis simple so that you can direct your treatment to the mechanism of sodium dysregulation instead of simply just following a recipe for raising or lowering the sodium concentration. Here with me in the studio is hospitalist Dr. J.K. Choi. For the past year, Dr. Choi has been an assistant professor of internal medicine here at Ohio State University, and next year he'll be an assistant professor at Virginia Commonwealth University. J.K., welcome to the program.
Thank you. Thank you for having me, Jim.
Well, J.K., in your practice as a hospitalist, how often do you manage sodium disorders?
It's probably the most common electrolyte anemia that we see.
What are some of the signs and symptoms of sodium levels that are either too high or too low?
So they tend to overlap quite a bit. So we tend to see nausea and vomiting, some weakness, maybe some muscle weakness, fatigue, and then in more severe cases, see seizures and coma.
Well, thanks, J.K. Before we get started, let me remind you that you can send Dr. Choi your questions about sodium and water balance using the email feature at the bottom of your webpage. And now let's take a look at sodium and water balance in the human body.
So to sum up, sodium is an electrolyte which is very important for maintaining blood pressure, and it is also needed for nerves, muscles, and other body tissues to work properly. Now let's watch another video about hyponatremia.
We'll now be talking about the condition of hyponatremia. Now, hyponatremia is when we see levels of sodium less than 135 milliequivalents per liter in the blood. And there's some important things to remember all the time about sodium. First of all, it is the most abundant electrolyte in the extracellular fluid, and it is a good indicator of the body-water balance. Water follows sodium. So that always helps you figure out what's going to happen when you have changes and shifts to an inadequate amount of sodium. The other key point to think of when we're talking about sodium is that the kidneys are responsible for excreting sodium from the body. So any changes in the kidneys are going to affect your sodium balance. So what is the picture here? Well, we have someone who has ears and has a very fatigued look. And the overall body appearance in terms of hydration will vary depending on if we're talking about a depletional or a dilutional hyponatremia. And I'll talk a little more about that in just a minute. There's confusion. And we also see a sense of kind of feeling nauseous, kind of green in the stomach, not hungry, and sometimes vomiting, which again, if you think about what happens with fluids during vomiting, it's a problem. There's also muscle cramps, weakness, and fatigue. Sometimes you'll see tremor. We can also see changes in the blood pressure, which, again, depending on whether it's dilutional or depletional, may end up being elevated or decreased. So if we talk about dilutional hyponatremia first, we see signs and symptoms consistent with hypervolemia. And because there's excessive water in the system, you have a dilutional low sodium level. So much water in ratio to the sodium produces that dilutional hyponatremia. So the situation here would be a high blood pressure, weight gain, typically a bounding rapid pulse, and a high urine-specific gravity. When we talk about depletional hyponatremia, this is often seen with hypovolemia. In other words, there's been so much fluid loss that there's been a corresponding sodium loss. And in this presentation, the patient has a low blood pressure, dry skin, and a low urine-specific gravity. So they're really excreting a lot of fluid or losing it in other ways, such as vomiting. So two different causes creating the same sodium imbalance of hyponatremia. So what's the nurse to do? Well, first of all, if possible, always look for the cause of the imbalance with the fluids, and if possible, address that. If there's been inadequate sodium intake, certainly it's easy enough to increase sources of sodium, but to tell you the truth, in the American diet, Western diet, that's hardly ever the case. Treatment for hyponatremia. Mild cases, we talk about restricting fluid intake. This would be in the condition of dilutional, and offering oral sodium supplements as ordered. In severe cases of depletional, then the approach may be to use isotonic IV solutions or hypertonic IV solutions. Close monitoring of intake and output, and because of our concern with confusion and fatigue and the muscle tremor, safety's a big issue. Also monitoring neurochecks closely, because sodium shifts in the brain can have big consequences for cognition.
So many possible conditions and lifestyle factors can lead to hyponatremia, including dehydration, for example in athletes, and also burns that affect a large area of the body, diarrhea, sweating, vomiting, also diuretic medicines, heart failure, liver cirrhosis, syndrome of inappropriate antidiuretic hormone secretion, and water toxicity. So most of the patients are asymptomatic, and symptoms don't usually appear until the plasma sodium levels drops below 120 milliequivalents per liter. The symptoms of hyponatremia most of the time are non-specific, like fatigue, headaches, and loss of appetite. In cases of severe hyponatremia, neurological and gastrointestinal symptoms predominate, for example, confusion, seizures, cramps, and muscle weakness. Now, applications in medicine. In order to diagnose hyponatremia, we first have to make a blood test measuring. Blood test measuring is required to confirm the diagnosis. Also, the medical history will suggest the diagnosis. And in other cases, urine tests and imaging may be needed to determine the acute cause of hyponatremia. And finally, the medical treatment. We first have to treat the underlying disease if it is possible, also make fluid restriction, provide oral or intravenous sodium chloride in patients, and administrate diuretics like vasopressin receptor antagonists. Some of the diseases related to hyponatremia are acute kidney failure, heart failure, and cirrhosis. So let's watch a video about cirrhosis.
The liver is an organ located in the upper right side of the abdomen, and it is part of the digestive system. It performs several life-sustaining functions. It processes nutrients, produces proteins, stores sugar or glycogen, and it also controls the body's hormone levels, blood sugar levels, cholesterol levels, and fluid retention. The liver filters unwanted substances and helps the body fight infection. Cirrhosis is a chronic progressive liver disease that prevents the liver from functioning normally. This disease is most often caused by chronic alcoholism, but can also be caused by hepatitis infection and other illnesses. Damage to the liver from alcoholism or illness causes scar tissue to develop in the healthy liver tissue. Scar tissue prevents blood from flowing through the liver, preventing it from functioning properly. If the underlying cause of cirrhosis continues, for example, if a person with alcoholism continues to drink alcohol, cirrhosis will progress and liver function will diminish. Even if the cause of cirrhosis is corrected, the damage to the liver cannot be repaired or reversed.
Now let's watch a video about heart failure.
Despite ongoing advances in the management of chronic heart failure, patient outcomes for acutely decompensated disease have not improved. Across Canada, patients hospitalized for heart failure continue to suffer frequent complications, and 16.5% die during their initial hospitalization. An examination of the pathophysiology of acute decompensated heart failure identifies promising new avenues for treatment. During heart failure, the heart cannot circulate enough blood at normal cardiac filling pressures to meet the metabolic needs of the brain, kidneys, heart, and other vital organs. The body responds by releasing neurohormones. Certain neurohormones help maintain blood pressure, but over time, they cause heart failure to worsen. One of these neurohormones is renin, released by the kidneys in response to decreased perfusion and increased sympathetic activity. Renin activates the renin-angiotensin-aldosterone system, or RAAS, by cleaving angiotensinogen in the liver to produce angiotensin-1, which is further converted to angiotensin-2 in the lungs. Angiotensin-2 binds to blood vessel walls, causing vasoconstriction. Angiotensin-2 also stimulates release of endothelin from endothelial cells. Angiotensin-2 and endothelin act on vascular smooth muscle, causing constriction of the coronary arteries and systemic arteries and veins. While vasoconstriction helps maintain blood pressure, it can also have maladaptive effects. For example, the weakened heart must pump harder against increased resistance in the systemic arteries, while constriction of the coronary arteries further compromises the myocardium's supply of oxygen. Venous constriction also contributes to displacement of fluid into the lungs and other tissues. Angiotensin-2 stimulates the adrenal glands to release aldosterone. Aldosterone causes the kidneys to reabsorb sodium into the bloodstream, and with it, water. Sodium and water retention cause a state of fluid overload that is exacerbated by venous constriction. Gaseous exchange in the lungs is inhibited by pulmonary edema. Build-up of fluid in and around the lungs increases the physical work of breathing. Patients with acute left-sided heart failure feel short of breath and fatigued. When right-sided heart failure occurs, fluid accumulates in the liver and legs. Apart from the activity of the RAAS, the body tries to maintain blood pressure using other mechanisms, such as releasing epinephrine from the adrenal glands and norepinephrine from sympathetic nerve endings. These catecholamines increase heart rate and contractility, in addition to causing arterial and venous constriction. Over time, chronic volume overload and the activity of angiotensin-2, aldosterone, and endothelin stimulates pathologic cardiac remodeling. The interstitial fibrosis and myocyte apoptosis associated with cardiac remodeling decrease heart wall elasticity, further inhibiting the heart's ability to relax and pump effectively. In summary, the neurohormonal response to heart failure causes vasoconstriction, fluid retention, and increased heart rate and contractility. In turn, these processes initiate a vicious cycle of further myocardial injury and escalating heart failure. Fortunately, additional neurohormonal responses modulate the activity of the RAAS, endothelin, epinephrine, and norepinephrine.
Now, last but not least, let's watch a video about cirrhosis.
which lie on the right and left side of the spine. The kidneys produce urine. The urine flows from the kidney through the ureter to the bladder. The bladder passes out the urine through the urethra. Kidneys have three important functions. They filter harmful waste products from the blood and drain them out via urine. They balance the level of fluids and salt in the body. They produce hormones. Chronic kidney disease occurs when there is a change in the structure or function of the kidney. An infection, damage, tumour or side effect of certain medications can cause kidney diseases. A kidney disease often has great implications on health and the functioning of the rest of the body. If you're suffering from a kidney disease, kidney failure can occur. In that case, your kidneys are not able to filter waste products and fluid adequately from your blood and extract them from the body. When the kidneys don't function properly, you might have the following symptoms: fatigue, nausea and loss of appetite, skin itching, high blood pressure, difficulty in concentrating, difficulty in sleeping or excessive sleep, shortness of breath. If the kidney functions can't be restored and both kidneys fail, then dialysis is needed. It is necessary if the function of the kidneys is less than 10%. The function of your kidneys will be performed artificially. There are two major types of dialysis, hemodialysis and peritoneal dialysis. In hemodialysis, your blood is filtered through a dialysis machine outside your body. In peritoneal dialysis, a dialytic fluid is flushed through your abdominal cavity, extracting the waste products from your blood. An alternative for dialysis is kidney transplantation. You get a healthy kidney from someone. Your general practitioner can give you more information about the disorder and its possible treatments.
And thank you for watching.